Good afternoon, everyone. Welcome to our last Global Health Seminar in this semester, and with a special designation of a Global Health Symposium. This is something we hold at the end of every spring semester. We've done this a couple of times, maybe 4 or 5 times, where we specifically focus on student research that kind of cuts across, but mostly has a global health aspect to it. Students that we work with, or students who are doing some global health research across campus. So today we have 4 very special speakers that we have lined up. And as you can see on the slide that is up right now, we have Devan Campbell, we have Laura, we have Adenike, and we have Trang. Again, I'm not going to read the entire bio. That's why I have it up for you to see the details. But I wanted to make a special note that this presentation, this symposium is really special because we get to see a showcase of the work that our students at different levels are working on. So in this particular case, we have 2 PhD students. We have a Master's of Public Health in Epidemiology, and we have Trang, who is a postdoc. So again, it gives you a whole feel for the kind of research that our students are undertaking in global health. So I would like us to proceed. Each student has 10 minutes to speak, and then we will have the presentation at the end, at the Q&A right at the end, just to allow each one of them to have, each one of our speakers to have enough time to present. And then I would also encourage you to write your questions for each presenter as the questions come up in the chat. And so that at the end, we'll not just sort of pause and wait for people to pop questions, just write them, and then we'll just go up and pull them up during the Q&A session. So that's sort of the housekeeping here. And we are going to have Devan, and we're going to have Laura and Adenike and Trang present in that order that you see in the slide. Okay, so without any further ado, I would like to invite Devan to go ahead and share his slides and start off with his presentation.
All right, can everybody see my slides?
I can see them okay from my end.
Yes, I'm seeing.
Oh, perfect. Okay, I'll get started then. Well, once again, my name is Devan Campbell. Thank you all for the opportunity to present here at this research symposium. I'm going to talk to you all today about the factors associated with personal exposure to Black carbon among rural pregnant women in 4 countries. So first, I'm going to start with a brief overview. I'm going to introduce household air pollution, as well as my study objectives. And then I'm going to talk about my methods for the paper, some main results, and then end with a conclusion. So introduction. So household air pollution is really a global issue. As we can see from this graphic here, the countries with the highest proportion of population that uses solid fuels are going to be in Latin America, Sub-Saharan Africa, and parts of South and Southeast Asia. And approximately 3.8 billion people rely on solid fuels for household energy needs. Now, these energy needs come in the form of cooking or heating, and sometimes even lighting in the home. And household air pollution is a leading risk factor in the global burden of disease and was attributable to approximately 2.3 million deaths in 2019. Now, these adverse health effects disproportionately impact both women and children in low and middle income countries. Now, Black carbon is a major constituent of household air pollution, and it has been gaining regulatory attention due to its potential to detrimentally impact both the climate and human health. And Black carbon from residential biomass burning is actually a major source of Black carbon globally, constituting approximately 35% of global emissions. And these global emissions from residential biomass burning are expected to increase due to population growth in low and middle income countries. So problem statement. Currently, our understanding of the levels and drivers of Black carbon exposure is limited, particularly in low and middle income countries. And Black carbon exposure studies to date have largely been cross-sectional and limited in their geographic scope. So therein lies a need for more longitudinal analyses of personal Black carbon measures on a global scale to further elucidate how space and time-dependent factors can potentially impact HAP-related Black carbon exposures. So my study objectives, I have two. The major objective is to assess the association between personal Black carbon and select individual and group level factors among pregnant women across 4 rural, low and middle income countries. And as a secondary objective, once we we identify the factors that are associated with Black carbon exposure, we then want to evaluate how these select factors modify or potentially modify the effectiveness of an LPG stove and fuel intervention in reducing exposures to Black carbon. So now I'm going to get into the methods. So I'm going to give a brief overview of our parent study called the Household Air Pollution Intervention Network Trial, or the HAPIN trial. Now, this is a randomized controlled trial of an LPG stove and fuel intervention across 4 study sites located in Guatemala, India, Peru, and Rwanda. In total, we have 3,195 pregnant women enrolled, and information on 24-hour Black carbon exposure, as well as factors expected to influence exposure, was collected at each of our visits. The first visit was conducted at baseline when the pregnant woman was at 9 to 20 weeks of gestation. This is before they were randomized into either the control and intervention group, where the control group is going to continue to use whatever traditional biomass stove that they were using beforehand, and the intervention group was expected to use the LPG stove intervention. After they were randomized into the control intervention group, we then followed up with post-intervention visits 1 and 2 at each of the study sites. So now our stat plan, we used a backward selection procedure to develop mixed effect models to first characterize major predictors of prenatal Black carbon exposures, but then assess each predictor as a potential effect modifier for the Black carbon exposure contrast between these treatment arms post-randomization. So for our first objective, the parameter of interest are going to be these coefficients for the covariates included in the model. And then for our second objective, the parameter of interest is this interaction term between the treatment arm as well as the covariate included in the model. And we did this after restricting all of our data to that which was collected post-baseline. And we did this separately for each of our predictors. So some main results. Here we show a graphic which is showing the HAPIN-wide multivariable linear regression coefficients for the Black carbon model. Now, these coefficients are going to represent the mean percentage change of the geometric mean on respective Black carbon exposures in comparison to a reference category or reference group. The statistical significance of these coefficients are going to be color-coded, where P less than 0.05 are going to be shown as black dots, P less than 0.01 are going to be shown in blue dots, and then P less than 0.001 are going to be shown in red dots. Now, to start things off, we see a lot of variation in Black carbon exposures according to study site. So those individuals, those pregnant women that live in India and Peru are shown to have lower exposures than those that are living in Guatemala. We also see that participants using LPG stoves are going to have lower Black carbon exposures than those that use open fire stoves. We see that our participants that are using the kerosene lamps as their primary lighting source have elevated exposures in comparison to those that use electricity as their primary lighting source. And we see that participants that actually cooked during the sampling period had 20% higher exposures than those that did not cook. And those that used kerosene during that 24-hour period of sampling had 47% higher exposures than those that did not use kerosene during the sampling period. Here we show the Black carbon exposure contrast between arms. Now, this is going to be the exposure contrast between the control group and the intervention group. We have it shown for HAPIN in India, in Peru, and Rwanda. I don't have any reporting from Guatemala because there was no evidence of effect modification for this study site. On the right-hand side of this screen, you're going to see the sample sizes for the relevant comparison groups in both the control and intervention arm. These triangular dots here are going to be the effect estimates that were reported in Johnson et al. 2022. Now, these are going to be the crude effect estimates for the exposure contrast between the control and intervention group. And the dotted lines are going to show the confidence intervals for the effect estimates reported in Johnson et al. 2022. Now, any deviations outside of this confidence interval is then going to provide evidence of potential effect modification for that contrast between the control and intervention group, according to the relevant subgroups that you see that is highlighted there. And also, any deviations to the left of the confidence interval is going to have evidence that the contrast between the groups was enhanced. And any deviation to the right is then going to provide evidence that the contrast was then attenuated. For example, the contrast between the control and intervention group we show evidence that the contrast was actually higher in India and Peru relative to that in Rwanda. We see that the contrast was attenuated for participants that did not adhere to the study stove assignment. Now, this is going to be an instance where the control group is using an LPG stove, and then the intervention group is using the LPG group is using a traditional biomass cook stove. We also see that the contrast is attenuated for participants that did not cook during the 24-hour sampling period. In India, we see that the contrast between the treatment arms was attenuated for those that used kerosene during the 24-hour sampling period. In Peru, however, we see that the contrast was actually enhanced for those that did adhere to the study stove assignment, as well as those that used their stoves for longer periods of time, as we can see from the first, middle, to up to the third quartile. In Rwanda, we see that the contrast between the control and intervention group was actually attenuated for both those in the other occupation category, as well as those that reported smoke from a neighbor's kitchen. So in conclusion, the study provides one of the most comprehensive studies on how certain factors influence Black carbon exposures among pregnant women in rural communities of low and middle income countries, and information, and we also provide information on the differential role that these select factors can potentially play in reducing Black carbon exposures via an LPG stove intervention trial. And our findings highlight the importance of protocols to improve stove adherence, assigned stove adherence, as well as mitigating kerosene usage in cook stove intervention trials. And as a next step, I actually want to incorporate postnatal personal exposures to assess the contribution of select factors and explaining the variance in Black carbon exposures, both within and between individuals. And I want to do this separately for the control and intervention arm post-randomization. I want to acknowledge my major advisor, my committee members, all of my lab mates, as well as the HAPIN collaborators, and especially the funders who without this, without them, none of the work that I've provided here today could be done. Thank you. Any questions? I guess we're doing the questions later, right?
That's right.
Okay.
So let's have the next presenter, Laura. Stop sharing and then we can have Laura.
I'm going to start sharing in a minute.
Yeah, please.
Share, screen, left.
Okay, we can see your screen. I can see your screen.
And use, but it is in presentation mode?
You can hit the presentation mode.
Hit it. I got it. It's there, right?
Yes.
Okay. So thank you very much, Dr. Sekandi, and also thank you very much, Dr. Whelan, for inviting me to the Global Health Symposium to present the research that I am currently doing. My name is Laura Grajeda, and today I'm going to present This topic, pulmonary function in 3-year-old children of the HAPIN trial, a validation study of forced oscillation technique in rural Guatemala. My presentation is going to have these sections. We're going to start with background, objectives, methods, results, and conclusions. As Devan told us, globally, around 2.4 billion people cooks daily with biomass in open fire or inefficient stoves, resulting in exposure to household air pollution. Look at the graph that I'm showing in the right. Household air pollution has been linked with many health damaging effects. For example, look at the green portion. It has been linked with chronic obstructive pulmonary disease. However, the evidence to do this link has some limitations. One of the limitations is that most of the evidence comes from other sources of air pollution, as could be outdoor air pollution or tobacco smoke. Other is that many of the studies come from high-income countries rather than low or middle-income countries where household air pollution is prevalent. And lately, to be able to study chronic effects, we need to have accurate assessment of the exposure through a long period of time, because chronic exposure have long induction periods, and epidemiological studies doing that are scarce. So because there is lack of information about the effect of air pollution on long-term impacts, and because we have this unique opportunity with the HAPIN study that have shown, as Devan showed us a little bit ago, good exposure contrasts, and because the HAPIN had several measurements of exposure during the lifetime of the child, we have decided to take advantage of this opportunity and submitted a proposal for the National Institute of Health, aiming to study the long-term health effects of early life exposure to household air pollution. The specific aims are illustrated in the figure in the left and are described in the right. I want you to please look your attention to the aim number 1 and aim number 3. The outcomes of these two aims are lung function and respiratory diseases on children aged 3 to 7 years. We are aiming to work with lung function as an outcome because lung function increases the likelihood of childhood asthma and also the likelihood of chronic obstructive disease later in adulthood. To measure lung function, we are going to use the forced oscillation technique. This technique measures the resistance and the reactance of lungs when a pressure oscillation is superimposed to normal breathing. Oscillation frequencies ranges from 7 to 41, with lower frequencies reflecting properties of the lower airways. As opposed to spirometry, this technique does not require performance of respiratory maneuvers, making it suitable for pediatric populations. However, some challenges exist for the study of FOD in child global health research. One of the challenges is that it requires 3-year-old children to breathe quietly through a device for 2 minutes. Also, it's required that the measurements are collected in the participants' homes in rural and impoverished settings in Guatemala, as opposed to clinical control settings. Also, we are interested in capturing typical lung exposure, lung function, instead of measuring acute changes. And then the reliability of this method has not been demonstrated in the current setting, and random measurement error that could result for low reliability might have an impact in result in loss of precision of the effect estimates of the main study. Because of this, before conducting the main study, we want to do this validation study, which has the objective to assess the reliability of measuring pulmonary function in 3-year-old children in rural Guatemala using the forced oscillation technique. Our validation study design consisted in 4 repeated tests per child. The data was collected between February to May 2022, and the participants were children graduated from the HAPIN trial when they turned 3 years old. Please follow me here with the design. Each child were assessed the lung function during 2 different consecutive days, day number 1 and day number 2. On each of the days, they had 2 tests, test number 1 and test number 2. Therefore, each child can have between 1 to 4 tests. Then each test is composed of the average of up to 8 measures, 20 seconds each. So to organize this data that has multiple levels, the first step is to summarize the measures to obtain test averages. And then to study the reliability, the second step is to calculate the intraclass correlation coefficient from the tests. More about the analysis. As I told you some seconds ago, the first step is to obtain test averages. We can do this by different methods. We decided now to do 2 approaches. Approach number 1 consists on selecting the first n measurements, that could be 1 to 5, and compute the average. The second one will be select the first n measurements that produce a coefficient of variation that is less of 15%. We are using this approach because the manufacturer of the oscillometer recommended, but we want to test it. So what I am saying here is, what's the difference in the reliability if I only take 1 measure? Or what happens if I take the first and the second measure, compared to what happens if I take the average of the first, the second, and the third measurement, and so on until I have all my measurements. This is important because random error decreases as the number of measurements increases. So ideally for our research, we want more measures. However, this has implications for the conduction of the research because more measurements represent more burden to the participant and also more resources. So we have to find this good balance between less random error and good resources. The second step was to calculate the intraclass correlation coefficient. To doing that, we use a mixed model with a random intercept. Here I have the model. In the left side of the equation, I have the resistance at 7 Hertz for each child and test. And in the right side, I have intercept and a random intercept, which is going to be able to capture between variability, between child variability. Then I have fixed effects for day, fixed effect for test within day, and an error term. Because the tests were conducted so close in time, we assume that this error term is mostly composed of measurement error. And then to find the intraclass correlation coefficient, I use the variance between child and divided between the total variance. The intraclass correlation coefficient can be interpreted as the proportion of the total variance in lung function due to between child differences. This slide shows you the participation and completeness of our data. 130 children consented for 3-year-old visits. From them, 98% attempted full tests, and from them, 66% had at least 1 valid foot measurement. You see here the challenges of working with this age. And then on the right, we have the completeness of our repeated testing. For example, 88% of our sample had the 4 tests that we were requiring. And now these are the results for our intraclass correlation coefficients. See the figure. In the y-axis, we have the intraclass correlation and the confidence interval. And in the x-axis, we have the number of repeated measurements, whether we use only the first measurement, the first 2, the first 3, or until the first 5. See how using only 1 measurement, the correlation is around 0.55. That means that if we do a study with only 1 measurement, our precision will be half because we have here a lot of random error that's going to decrease the precision of our estimate. As we increase the measures, the intraclass correlation coefficient increases. With 4 measurements, we have an intraclass correlation of 0.74. With 5 measurements, it looks like the intraclass correlation coefficient is going to be improved. However, here I don't have so many data points, so also the confidence interval are more wider. And in conclusion, we demonstrated high reliability of lung function tests in 3-year-old children in rural Guatemala if the test included at least 4 repeated measures. And the proportion of successful FOT attempts was lower than our target 80%. but we recognize this challenge early and have improved since then. Thanks. Questions to the end?
Thank you. Let's keep it moving. Next presenter.
Let me know when you guys can see my screen.
I don't know if we're seeing your, I don't know the screen, if we're seeing has questions at the end, so you probably have the last slide showing.
Mm-hmm.
Okay, so we have that, and now you need to put it in slide mode or presentation mode.
Can you guys see the slide?
Yeah, do you have it? You need to move it to presentation. Is it moving? I don't know if either your computer is hanging. Have you hit presentation mode, Adenike?
Yes.
Looks like it's still in slide mode, PowerPoint mode. So let's try one thing.
That better?
Okay, it
Okay.
worked. So it might drag on a little, so you have to be careful there. I don't know how you're going to manage that, but
Okay, and just a reminder for persons logged on in the chat, please send your name, email addresses, the institution that you're affiliated with. And if you're in any of the global health classes, please add that in the chat as well. Thank you. So my name is Adenike McDonald, and this is my presentation on the prevalence of TB-related symptoms and self-reported disability among adults post-TB treatment in Uganda. So just a brief overview of our study. We know that tuberculosis remains one of the leading causes of infectious deaths globally, accounting for approximately 1.6 million deaths per year. And now the burden of TB goes far beyond what happens before and during treatment, as we see where many patients suffer from several debilitating symptoms post-successful treatment. The most common complications that we see or that are reported are impaired lung function, a reduced quality of life for individuals, and also mental disorders. And even though post-TB disability has been a new area of priority, we do see that only a few studies have assessed the prevalence of TB-related symptoms and disability post-TB treatment. And this is where our study comes in. The aim of our study was to determine the prevalence of TB-related symptoms, self-reported disability, the factors associated with disability post-TB treatment among participants who completed TB treatment in Kampala, Uganda. So for our study, we had 101 participants who were previously a part of a VDOT clinical trial that Dr. Sekandi conducted in 2021. To be eligible for our study, participants had to be 18 years and older, and they would have had to complete treatment at least 6 months prior to the start of our assessment, which ran from January to June in 2022. We collected data on social demographics, TB-related symptoms, self-reported disability, and this was done using structured interviews. Our main outcome was self-reported disability, and we measured this using the World Health Organization Disability Assessment Schedule. The main version has 36 items with 6 domains and 6 questions under each domain. However, there is a 12-item version, and this is the one that we used in our study that still has the 6 domains of functioning with 2 questions under each, and I will show you a picture of that in one of my upcoming slides. Our exposures were TB-related symptoms, age, sex, HIV status, employment, and self-reported health status. For data analysis, we created a binary outcome variable for disability, which was yes or no. Yes being that the participant reported disability in one or more of the 6 domains, and no being no disability reported at all. We conducted simple and multivariable logistic regression, and all of this was done in the SAS software. So just going over our baseline and clinical characteristics, for the 6 exposure variables that we used, we saw where majority of our participants were female, they were employed, and they reported a good to very good health status on the day of the interview. We saw where approximately 26% of our participants were HIV positive. We had approximately 48% reporting 1 or more TB-related symptoms, and we had approximately 71% reporting disability in 1 or more of the 6 domains. For this table, we're looking at the prevalence of domain-specific disability, and here we have our 6 domains. We have cognitive, mobility, self-care, getting along, life activities, and participation, and we see where each has 2 questions. And the answers were answered on a Likert scale ranging from 1 to 5, 1 being no issues completing the activities at all, and 5 being extreme difficulty completing the activities or not being able to complete the activities at all. And we see where the mobility and participation domain actually contributed 51% of the cumulative disability score, which was 777. And the participation domain being one of the main drivers was not surprising to us, given the role that we know that stigma can play, and this is a possible association to that, as current studies show where both during and post-TB treatment, whether it be self-stigma, perceived stigma, or experienced stigma, can impact the reintegration of individuals into communities and into societies, not just during treatment, but also post-treatment. For this table, we're looking at the distribution of median disability scores based on the 6 factors or exposures that we're looking at. And for this, we should note that we did not use the binary variable of disability, yes or no. We used a continuous variable of total disability. And using that variable, we see where only TB-related symptoms, employment status, and self-reported health status seem to have a significant association with total disability scores obtained for participants. Looking at our logistic regression output using our binary outcome variable of disability, yes or no, for a crude analysis, we see where only sex and HIV status had a significant association, with females being 3.2 times more likely to report a disability. And this was not surprising, as it tracks with current studies that shows that even though males are more likely to acquire TB, females are more likely to, 1, have adverse events during treatment, but also to have worse off outcomes. And for our HIV status, we see where being HIV positive seemed to be protective, where HIV negative individuals were 2.9 times more likely to report a disability. And this could be attributed to one of 2 things. We did have a relatively small sample size, and only approximately 26% of our participants were HIV negative, but also given the fact that our study was based on tuberculosis and participants were aware of this, it could be a case where when they were answering the questions, if they were both HIV and TB co-infected and they had their HIV status prior to TB, they could be associating the similar symptoms and disability to their HIV status and not towards the TB status. And this could have led to an underreporting of any experienced symptoms or disability. After adjusting for sex, age, and HIV status, we saw where only sex remained significant, where females were now 2.9 times more likely to report a disability than males. So what are the conclusions and implications of our study? We see where TB-related symptoms and disability is definitely prevalent in high burden areas, with the prevalence of TB-related symptoms being approximately 48%, and that of self-reported disability being approximately 71%. And this highlights a need for interventions that targets this, as what happens to individuals post-TB treatment is a part of improving their quality of life, and therefore there's definitely need for interventions that targets this problem as well. The mobility and participation domains of functioning appear to be the main drivers, with the main drivers with regards to self-reported disability post-TB treatment. And this could mean that these factors are things that future interventions or programs would need to take into consideration once they're trying to tackle the issue of disability post-TB treatment. We saw where being female was significantly associated with self-reported disability, suggesting a potential for needed targeted interventions. And like I said before, our study did have a few limitations, one of which being a small sample size and the cross-sectional design that we use. And therefore, there is the need for larger studies using a longitudinal study design where we would be able to evaluate morbidity among persons post-TB treatment. And finally, there needs to be the creation of appropriate care programs that are geared towards supporting individuals post-TB treatment, as we see where TB-related symptoms and self-reported disabilities are prevalent post-treatment. And this is the end of my presentation.
Okay, so moving on, we have Dr. Quach, Trang Quach.
Yes.
Let's go ahead.
Yeah. Let me stay. And then, do you see the screen okay?
Perfect.
Okay.
Yes.
So, hi everyone. I will talk about the effect of restriction for the SARS-CoV-2 pandemic on the social and geospatial network of the tuberculosis in Kampala, Uganda. TB is the 13th leading cause of death and the second leading infectious killer after the COVID-19. In 2021, 10.6 million people were diagnosed with the tuberculosis and 1.6 million people died with the disease. In 2020, the SARS-CoV-2 entered Uganda to limit the transmission of the virus. The Ugandan government imposed restrictions on local travel, so-called gathering, and curfew in Kampala. These restrictions may have affected airborne transmission of tuberculosis from infectious case to susceptible contact in Kampala. Therefore, we examine the effect of the restriction on the social and geospatial network of tuberculosis in Kampala. We perform a cross-sectional study of tuberculosis case in Rubaga division of Kampala, Uganda, between August 2019 to May 2022. We use the network methods to assemble the social and geospatial network of TB cases. We enroll the adult with counter-confirmed pulmonary tuberculosis. We ask TB cases to list the social network member and the location where they spend most of their time over the past 6 months before diagnosis. For social network member, we ask age, sex, and household status. For the location, we record the frequency and duration of time spent, meet the social network member or not, indoor or outdoor location, crowded or not, and GIS coordinate. Now let's shift the gear to the result. We enroll 307 TB cases, and they listed 5,344 social network members and 6,278 unique locations. 77 social network members were seen at a listed location, and 54% of local location and location where TB case did not meet any social network member. In terms of the characteristic, the median age were 31, male accounted for 68%, HIV positive was 17%, BCG vaccination yes was 79%, the smoker were 23%, the alcohol user were 30%, and contact with non-TB in the past 1 year was 15%. Here is the graph of the social network. Because of complicated and difficult to interpret, we use the standard statistics to describe the graph. There are 4,435 nodes, including TB cases and their contact. Also, 91,171 connections are active between the nodes. The average degree is 23. This is the average number of connections per person. The average shortest path length is 3.5. It measures how close two people are in the network. The diameter EA presents the largest average path in the network. The average shortest path length and diameter tell you how large the network is. The clustering coefficient is 0.6, which is high and indicated that many nodes are clustering together. Finally, the component is 7. A component is a group of connected nodes that are not connected to the larger raft. And you see in the picture, the yellow node are the social network member, the red node is the TB cases, the red line, the red line connect two people who are at the same location. The take-home message is that the social network of TB cases is small, highly clustered, and highly connected to others. It's also so that TB cases are central to the network. For the Geo-Spatial network of TB cases, it includes 6,278 nodes and 38,640 connections. Among them, the average degree is 34. The average path length is 2.3 and the diameter is 5. The generalized clustering coefficient is 0.27 and there are 7 components. The take-home message is that the Geo-Spatial network of TB case is highly connected, although it is smaller and less clustered than the social network. We compare the network statistics across the period of COVID-19 restriction. This analyze, and here is for the social network. This analysis indicates that the social network did not change very much across the COVID-19 restriction. For example, the average degree, the average path length, the diameter, and the clustering coefficient are nearly identical before and during the restriction. In contrast to the Geo-Spatial, in contrast to the social network, the Geo-Spatial network were disaggregated as shown by the large number of components. In general, the Geo-Spatial network during the COVID-19 restriction were larger, less connected, but very highly clustered. For example, the degree reduced almost by the half from pre to during COVID restriction. Average path length and the diameter double. The number of components is from 3 to 43 during the COVID. In conclusion, although the network's characteristic of social network of TB cases remain intact during the COVID-19 restriction, the Geo-Spatial network was disrupted by separating individuals with tuberculosis into a greater number of highly clustered groups. Transmission of tuberculosis slightly continued among the social network contact, but may have been reduced to the incidental contact at some location. This project was supported by a grant from the NIH. There are many people involved in this study, both at Makerere University in Uganda and at UGA. My special thanks go to Dr. Noah, who lead the field research team in Kampala, and Dr. Wayland, who lead the field research in US. That's all my presentation. Thank you.
Thank you very much. Our presenters, you've done a fantastic job in keeping us on time, but also being able to relay that very interesting work results from the work that you're doing. So thank you again. We will move into our next session, which is the Q&A. And so the way I'm thinking to do this, I already saw some questions already in the chat. So why don't we tackle those? And if there are any more, please keep writing those in the chat. And then once we have covered the ones in the chat, we can go ahead and add more or have people just open up their mics. I think there was one, the speakers you can also check, but I think the first question that I saw drop in the chat was to Devan. So I'm trying to go back and see if I can pull it up. Let's see. Devan, are you able to see the question from Dr. Whalen?
Yeah, it says from Dr. Whalen, can you define, well, there's two questions from Dr. Whalen. Can you define what black carbon is? Is it a pure substance or a mixture of different pollutants? So in the most general sense, there's no universal definition for black carbon, but it basically describes a wide range of carbonaceous particles that have light absorbing properties. So it's not a pure substance at all, but it is a mixture of different types of pollutants, as you have put in your question. How we measure black carbon will signify what we might call it. So there's elemental carbon, which can be considered black carbon. Now this will be a pure substance. And that's measured through thermal desorption, all other types of techniques. There's refractory black carbon as well. These are just different ways that we can use the properties of black carbon to measure it. Your next question is, what is the effect of ventilation in the household using an indoor source of carbon? So generally we would see a reduction in exposures with increasing ventilation. I actually inputted that actual variable into my analyses, and it wasn't included in the model. I suspect that ventilation is more so a term for, as we asked in HAPIN, was more so a term for whether they had a chimney stove or whether they did not. So that's an unvented stove source or a vented stove source. I hope that answers your question.
So can I just ask a real follow-up question there?
Yes.
Clarifying question, really. So yes, for the ventilation capture of data was about the chimney, but was there information that was collected about the household setting? For example, how many windows and that kind of thing, I think would help.
Yeah, yes, there was. And those were not included in the model as well. I had information on number of doors. I had information on number of windows. Had a lot of different information. The information that you saw was what we think is as comprehensive as we could have gotten. Of course, there are some instances where we wish we would have asked questions in a certain type of way to get a little bit more specific, glean a little bit more specific information from that. But we feel like we did capture a comprehensive assessment of the built environment that the participant would be living in.
Excellent. Thank you, Devan. So moving along, I think the next question was to Laura, I believe. Laura, do you want to take a shot?
Yes, of course. Thank you, Dr. William, for your question. It was, can you define the terms resistance and reactance of the lungs? How do these measurements relate to lung function? Well, as someone breathes, the air comes into the lungs, and for the breathing to occur, some change in pressures occur, and the resistance will be the change in the pressure given the flow that the tissue and the lungs produce in because of the flow of the oscillation that is coming inside. So it's the resistance that the lung is doing to this oscillation that is coming. If the resistance is increased, but considering the age and the size of the lungs, more resistance will be associated with obstructive disease. And the reactance, as I understand, is the elastance or stiffness of the lungs. And also this one is the numbers, is also pressure by flow, by liters and seconds of flow, but this has negative values. So more negative values are associated with obstructive disease. Yes, so these kind of measurements are saying how the lungs are breathing and what is the health of the lungs, what resistance they are putting to breathe and how obstructed their lungs are. I hope this is good.
Yeah, thank you. Thanks, Laura. Next is another question. Dr. Whelan has really some very nice questions here for the presenters. So next is Adenike. Do you see the question? Or do you want me to read it out? You're muted. Yeah, looks like you're
I
muted.
thought I unmuted myself.
Okay, that's all right.
Thank you, Dr. Whelan, for your question. My question was, Adenike, what do you mean by post-TB symptoms? So for us, post-TB symptoms were symptoms that participants either experienced post-treatment. But the question that we asked, when we asked them if they experienced the symptoms, they had a variety of answers. So there was yes, being that the symptom was new, being post-treatment, being old, given that they had it either before or during their TB treatment, and it did not subside after they finished treatment. And the symptoms that we looked at were dry cough, productive cough, fevers, night sweats, weight loss, loss of appetite, and blood in sputum. And we had dry cough and productive cough having been the most prevalent reported symptoms, and blood in sputum and loss of appetite having less than 4% prevalence among our study population.
And I think there's another part. Do these symptoms indicate unresolved disease?
Right. No, these symptoms do not indicate unresolved disease, because at the end of the VDOT clinical trial, participants were tested to ensure that they were free of disease. And that would have been one of the criteria as well to be a part of this specific study.
I will say, though, it's also a sort of a hard question to be honest, because the way we evaluate patients at the end of treatment is, okay, one, you have completed treatment, and then two, you're able to produce a sputum to be able to check it for the mycobacterium. And so for the most part, most patients don't have a cough anymore, or they have a dry cough and they can't produce sputum. So that kind of takes away the opportunity for us to check whether there is mycobacterium in their sputum, obviously. So, but the most common parameter that is used is they have completed treatment and they are reporting in general that their symptoms have subsided. So I think, to Dr. Whelan's point, it could be still that there are people who have unresolved disease. It's just that we haven't evaluated them completely or comprehensively. But yeah, Dr. Whelan, if you have some other points to jump in there, but I'm going to check if there's another question here. Let's see.
There's one question for me.
Okay, Laura. Yeah.
Okay. So
Julia, before you move on, can I just clarify?
Yeah.
I think you need to give a lot of thought as to what I mean. This is a very ambiguous term, post-TB symptoms.
Yeah.
I think I didn't know what they meant. That's why I raised the question. Does it mean symptoms post-treatment of TB? Does it mean TB symptoms that occurred and continue after treatment? Which is what Adenike said.
Yes.
So I think you'll need a more carefully defined term to to specify what you're really measuring. Because it sounded to me like you were after TB symptoms following the completion of treatment, indicating that they continue to have disease.
Okay.
That's what I thought you were describing.
Yeah, TB-related symptoms post.
Right. So abdominal pain is generally not a TB symptom, right?
Yeah.
So, but cough is. So the persistence of cough seems to indicate to me that the TB may be unresolved. Whereas if they were complaining of abdominal pain and had no cough, that means something different, if you see what I'm saying.
Yeah, makes sense.
Anyway, that was ambiguity. I think I know what you were measuring, but it will be important, maybe using some sort of figure to
clarify,
illustrate what when you collect symptoms and what they mean.
That's correct. Okay, thank you for point noted, and Adenike, we will make some refinements in the definition and make it clear what it is that is being measured here. Laura, do you want to take a shot at your question here?
Yes. So thank you, Trang, for your question. It was, hi, Laura, the same person measures 4 tests or different person measure 4 tests. So our design was that each child was visited 2 days, 2 subsequent days. And on each day, it had 2 tests. So then each child has 4 tests, 2 in day 1 and 2 in day 2. And then the other level of the data is that each test is composed of measurements, each one of 20 seconds. And in this study, they have between 1 and 8 measurements, the mode being 4 measurements. The measurement that you compute the average of the measurement to have a test. Thank you.
That's clear. Thank you. Any other questions, comments from the audience? Still have a minute. No?
Yeah, I think my question is about who do the test on the children. So it means the same person do the test or different person do the test. So,
I now understand. You were asking who is the person who do the tests.
Yeah.
Yes, we have 2 persons that do the tests, but they have always the same role. One person is in charge on the machine mostly and doing the calibration or things that are needed for the machine, controlling the machine. And the other person is more of the side of the children, checking the children, maybe holding his cheeks and making the children cooperate with the study. They both have received training and they do it every time.
Yeah. As I know that we have different kind of reliability. One is inter-rater and another one is inter-rater between the observer agreement. And I think in your study, you do the within observer agreement.
I'll think on it as a test retest, but because it's the same rater, it will be inter-rater.
Yeah.
But the tests follow each other, are close to each other.
Did you leave? You muted.
Yes, I'm muted. I saw that. Sorry. Yeah, so we've come to the end of our time right now, and we would like to thank our presenters for this fantastic talk that you've put on for our Global Health Symposium. And I'd like to thank our audience. Thank you all for coming on, and we hope this has been informative and a rich presentation for all of us. And with that, I would like to just send a hand clap to all of you and hope you come again in the next seminars and in the next symposium. Thank you.
Thank you, Dr. Sekandi.
Thank you so
Thank you.
much.
Thank you for having us.
Yeah, you all did a great job.
See you guys next week, Tuesday.
Yeah.
We are presenting our posters for the MPH program. So
Oh, I see.
yes.
That's a good plug in there.
Yes.
Yeah. Okay, so you wanted to take the attendance, right?
Yes.
Have you been
Bye.
able to?
Bye, Kaylee. I love you.
Was
That
it
was one of my
yes?
family members.
Oh, wonderful. This is good.
Yeah.
When you have it on Zoom, you can invite people. Was that person in Jamaica?
Yeah.
Wow, that's awesome. And have a broad of the audience, obviously, with
Yeah.
you.
I took a picture of the persons who were here, so I'll just put that in an Excel file.
Okay. Sounds good.
Mhm.
I see Dr. Whelan is still on, so I'm not going to cut him off. He probably has something to say. I don't know.
Thank you for your question again, Dr. Whalen.
Sure.
I don't know if
No,
you.
Juliet, I was actually just typing you an email, so
Oh, oh.
so you can
So yeah.
so you can continue your discussion.
No, that's all right. We thought you probably had something to add. I did what.
No, it's just
back.
very, very nice. And yeah, there's a lot of interest in the lung health in TB patients.
Right.
Yeah, most of the studies that I've been finding have been assessing lung function post-TB treatment.
Yeah.
Yeah.
One question I don't know is immediate lung health, like what is happening to the lungs in say the first year after treatment
Mhm.
versus 5 years later.
Right.
I did
So-
find a study that assessed it 3 years after that I could share with you.
Yeah. Anyway, I just think that the holes in the lung don't go away.
Right.
Mhm.
They only get worse.
Mhm.
And the interstitial, the bronchiectasis that occurs, the asthma that can occur, the pneumonias, cancers, and so on. All those things have long-term consequences. And I just think it would be a neat study to go to the NTLP, try to trace people 10 years ago.
That's
and
right.
do some sort of, get 10 people per year for 10 years, 100 people, and then have them do pulmonary function testing and questionnaires like you had and that sort of thing.
Right.
I think that's the kind of, that would be very interesting.
Yeah. That's
Unfortunately, it's not longitudinal, it's pseudo-longitudinal, but
yeah. Yeah, in some ways, I mean, if you could set up a long-term longitudinal, you would get the ones like the ones we had, the 100 and whatever case people that completed, and just follow them over that period of time and just keep measuring their lung function. So that is sort of what I was thinking when I said the longitudinal aspect or evaluation of the physiological changes. And I mean, we really focus more on the emotional, psychosocial, and a few physical things. But yeah, definitely the lung function is the way to go in terms of really measuring where the problems are.
yeah.
Those who had pulmonary TB and of course those who had extrapulmonary, then of course it will be probably other things.
Yeah, I think the TB program should collect biometrics on all TB patients, eye scan and facial recognition pictures, and that be loaded into a database that anyone in the country can access. If a person comes in and says they had TB, you just snap a picture of them and find them in the database. And even if they're in Fort Portal when they were treated, but they are living in Kampala, you'd have a way to track people. Anyway, lots of interesting things, and it's a wonderful